Good morning, everyone. I see that people are still entering the room back there, which is amazing. If you could please take your seats. So let's start and welcome everyone. Good morning. Good morning. Good morning. Warm welcome to this first day of the ICM Triennial Congress 2026. And I have to thank every single one of you for the engagement, the dancing, the singing, and the joy you shared with all of us yesterday. Thank you so much. I am still on the high. Adrenaline is very high and very energized. And I really look forward to these 4 days ahead together. Today, I would like to honor midwife associations that were not in the march yesterday. Guatemala, please give them a round of applause. Myanmar. Bahamas. Guinea-Bissau. Costa Rica. And Fiji. To the 6 of you, we made a mistake yesterday in the schedule, and we apologize for that. Please join me in welcoming all of them. But while we think about all your joy, I also would like to recognize the colleagues that are not here with us at this Congress. I mentioned it a little bit yesterday, but really to reiterate that they are very much with us during this Congress. Those are the midwives whose visas were rejected. Those were the midwives who could not leave their families. Those were the midwives who could not get their funding to come. And those were midwives who live and work and struggle in crisis and humanitarian settings. The midwives who are at home doing all the work. We start this Congress with all of you in mind and commit to sharing all our experiences and learning with them. Today's work begins with our first plenary session. This year's plenary session will start with a keynote presentation, followed by a moderated panel discussion. And before we go into that, please allow me to just remind you of the AI interpretation that is available in this room. If you use the app Go in there and you can access the AR interpretation. If any issues, please visit the registration desk and they will help you to get it installed. Today's topic is 1 million more midwives. Again, 1 million more midwives. Again, 1 million more midwives. And how midwives drive and support health systems. I'm extremely honored to welcome our first keynote speaker, Magda Roballo. She's the president and co-founder of the Institute of Global Health and Development in Guinea-Bissau. Please welcome Magda.
Thank you very much for that very warm welcome. Good morning, everyone. Please join me in saying again and again, 1 million more midwives. It is indeed a great honor for me to be here today with you at the opening plenary of your 2026 Congress in Lisbon. I want to thank the International Confederation of Midwives and the Associação Portuguesa dos Enfermeiros Obstetras for the opportunity to join you at this important Congress. It is a privilege for me to be part of a global gathering that brings together midwives, researchers, educators, policymakers, and advocates, united by a shared commitment to improve the health and the well-being of women, of newborns, of families, and communities. Colleagues, distinguished guests, leaders of the midwifery profession, and partners, the theme of this Congress, 1 million more midwives, is both a call to action and a reminder that investing in midwives is among the most powerful investments we can make in health equity, in gender equity, and sustainable development. To understand why this theme matters, we must first recognize the central role women play in health systems worldwide. Women comprise nearly 70% of the global health and care workforce. Women provide essential services to an estimated 5 billion people and contribute more than $3 trillion annually in paid and unpaid health and care work. Women are the backbone of health systems. Yet, despite representing the majority of the workforce, women remain significantly underrepresented in leadership. Approximately 3/4 of leadership positions in global health are occupied by men. women are also more likely to be concentrated in lower paid, lower status, and often unpaid roles, while continuing to face barriers to career advancement, leadership opportunities, and equitable compensation. This imbalance matters. It matters because who leads influences what is prioritized, what is funded, and implemented. When women are absent from decision-making, health policies and investments risk overlooking critical perspectives and lived experience that are essential to building equitable and effective health systems. These inequities are particularly evident in midwifery. Women comprise approximately 90% of global midwifery workforce, making midwifery one of the most women-dominated professions within the health sector. Midwives are indispensable providers of care across the life course, delivering maternal, newborn, sexual and reproductive health services, family planning, health promotion, and essential newborn care. Yet, their expertise remains insufficiently reflected in leadership, in governance, and policy decision-making. This leadership gap is compounded by a global shortage of nearly 1 million midwives, with the greatest deficits concentrated in Africa and other resource-constrained settings. And the consequences of these are profound. The evidence from the Lancet series on midwifery demonstrates that universal access to quality midwifery care delivered as part of an integrated health system could avert more than 80% of maternal deaths, stillbirths, and neonatal deaths. I was just having a conversation with the executive director of the Confederation of Midwives, and I was telling her that I'm the firstborn of 6 children my mother had. I was the only one born in a hospital. My 5 siblings were born at home, helped by a midwife who was a neighbor of ours, and then she lived next door. I am forever grateful to that midwife who safely delivered my 5 siblings. They were all healthy and led their lives because they had the support during my mother's delivery of that midwife who happened to be next door. Midwives are closer to where people live. I was talking about the evidence from the Lancet series on midwifery, which demonstrate that more than 80% of maternal deaths, stillbirths, and neonatal deaths are averted by universal access to quality midwifery care. This makes investment in midwifery one of the most effective strategies available to improve maternal and newborn outcomes, strengthen primary health care, and advance universal health coverage. However, strengthening the midwifery workforce is not only about increasing numbers. It is also about ensuring that midwives have the resources, have the recognition, have the protection, and the authority they need to lead. When I reflect on these challenges, I am reminded of my own leadership journey. Throughout my career, from serving at the lower level, at program level, at the Ministry of Health, to becoming the Minister of Health, the High Commissioner for the COVID-19 response in Guinea-Bissau under the President's Office, to leading communicable disease programs at the WHO Regional Office for Africa, or serving as WHO representative to Ghana and to Namibia. And now, as Acting Executive Director of Women in Global Health, I have often found myself in rooms where women were underrepresented in decision-making. I am fortunate to have had a career that allowed me to serve in leadership positions at the national, regional, and global levels. Yet, like many women leaders, I have experienced moments when my expertise was questioned, when I had to work harder to have my voice heard, and when institutional barriers limited access to leadership opportunities. It has been a tough journey, compounded by the fact of I am a woman. Yet, I have also witnessed the transformative power of women's leadership. I have seen our women leaders build coalitions, strengthen accountability, challenge inequities, and champion policies that are more responsive to the needs of women and their communities. I have learned that leadership is not about holding a title. Leadership is about influencing change. Leadership is about creating opportunities for others. Leadership is about having the courage to speak when it matters the most. It is also a right, the right to participate in decisions that affect our lives, our communities, and the future of our health systems. That's why I would like to speak directly to the midwives in this room and those who might be joining us from around the world. Too often, midwives are viewed solely as providers of care. Too often, midwives are seen as solely providers of care. But midwives are much more than that. You are advocates, educators, researchers, innovators, community leaders, and agents of change. Every day, you make decisions that affect the health and the well-being of women, newborns, families, and communities, every single day. You possess knowledge and experience that should inform policies, programs, and investments. The future of midwifery depends not only on having 1 million more midwives, it depends on having 1 million more midwife leaders. We need midwives serving not only in clinics and communities, but also on hospital boards, professional associations, research institutions, ministries of health, parliamentary committees, and global health governing bodies. We need midwives helping to shape policies. We need midwives influencing budgets. We need midwives guiding reforms. And we need midwives holding decision makers accountable. My message to every midwife is simple. Do not wait for permission to lead. Because your expertise do matter. Because your voice do matter. and because your lived experience do matter. Leadership begins wherever you are, whether at a bedside, in a classroom, in a community meeting, or at a policy table. Investing in women and in midwives is not only the right thing to do, it is one of the smartest investments a country can make. There is growing evidence that gender equity in women's leadership generate measurable health, social, and economic returns. Research suggests that closing the women's health gap could add at least $1 trillion annually to the global economy by 2040 through increased productivity, workforce participation, and improved health outcomes. Women currently spend approximately 25% more of their lives in poor health than men. Closing this gap is not only a matter of rights and health equity, it is one of the smartest investments we can make in human development, economic growth, and societal well-being. Similarly, investing in women health workers strengthens workforce retention, improves performance, and increases health system resilience. When women participate meaningfully in leadership and governance, institutions benefit from more inclusive decision-making, stronger accountability, greater responsiveness to community needs, and more equitable policies. For midwifery, the return on investment is especially compelling. Investments in education, employment, leadership, and professional development yield benefits not only for women and newborns, but for families, for communities, for health systems, and national economies. Gender equity and women's leadership are not costs, they are investments. When women lead, health systems become more responsive, more accountable, and resilient. When women health workers are valued and supported, communities are healthier. And when women and girls are able to achieve their full health potential, societies prosper. So, what must we do? I have 5 proposals for you. First, we must invest in the education, employment, protection, and retention of midwives. Second, we must ensure that midwives are fairly compensated, supported, and able to work in safe and enabling environments. Third, we must create pathways for midwives to participate in leadership, governance, and policy making at every level of the health system. And as I speak, the global health reform is taking place in different spaces around different institutions. This is the opportunity for you to make sure your voice is heard. This is an opportunity for you to influence the process, to influence the outcomes, and make sure midwives have a seat at the table when global health reform is being discussed. Fourth, we must challenge the gender norms and institutional barriers that continue to limit women's opportunities and influence. And finally, We must recognize that the goal is not simply to add 1 million more midwives. It is 1 million more midwives who are empowered, respected, adequately resourced, and able to lead. And this is because the future of maternal and newborn health will not be determined solely by the services provided by midwives. It will also be shaped by whether midwives have a seat at the tables where decisions are made. When midwives lead, health systems become stronger. When women lead, communities become healthier. And when women and midwives are able to realize their rights and full potential, societies prosper. Let us commit not only to investing in midwifery, but investing in midwife leadership. The health of future generations depends on it. I thank you.
Following on from Magda's amazing presentation, a call to action actually for all of us. I mentioned yesterday that ICM believes that every midwife is a leader, and we're going to continue with that theme that was just shared now, that call to action, those startling accounts and narrative about how difficult the journey can be. I know there are many midwives in this auditorium. Personally, myself, the journey isn't always easy, but we keep moving forward. So Magda, amazing, amazing presentation. And we're going to follow on with that now. So, of course, you're in the plenary, and the focus is how midwife leaders drive health systems forward. How we drive health systems forward. So that's where you are today. We've heard from Magda, and now we're going to hear from 4 excellent panelists who are here because they have something significant to say to you based on their experience. So I'm just going to ask them to introduce themselves, starting to my left here.
Thank you, Jacqueline, very much. My name is Indrajit. I'm proud to be the Director of Midwifery at the Fernandes Foundation in Hyderabad, India. I am a midwife from the United Kingdom, and I came to India in 2017 on a sabbatical, and I'm still there. I've spent 9 years working to embed midwifery, working in public institutions, collaborating with the government of India, state governments, and partners. Thank you, Jackie.
Okay, hello everybody. My name is Dr. Jama Ali Igal. I'm a UK-trained midwife, and I am representing Somaliland today because thank you. I am a midwife who returned home in 2014 to Somaliland. Currently, I'm the executive director of the Somaliland Nursing and Midwifery Association. Very proud to be with you here today. I have a background in education, regulation, and midwifery research. Thank you so much.
And hi, I'm Jackie Lambert. I'm the director of the Royal College of Midwife in Scotland, and I am a Scottish midwife of 30 years' experience. And I'm here because my DNA is midwifery-led care, which I built on leading and developing and co-producing a midwifery model of care along with 5 standalone midwifery-led units in Scotland and with the women that we cared for, where we had no vacancies because midwives thrived, because women thrived. And I took that learning into my job in government as an advisor and into my work with the Liverpool School of Tropical Medicine, where my understanding of building social capital came from working with the data from 140 hospitals and realising you need a different approach. And that's what I do in the role that I'm doing today, building social capital in our amazing community.
Good morning, everyone. My name is Sylvia Hamata. I am a midwife, a public health lawyer as well. Very happy to be here today. I bring over 15 years of experience in regulatory affairs, as well as sexual reproductive health and rights. Looking forward to having this discussion today and sharing the work that I've done as a midwife and balancing the law and the within the healthcare systems. Thank you.
So I'm the moderator for this session today, and my name's Jacqueline Dunkley-Bent, and I'm the Chief Midwife at the ICM. And of course, the theme, we've heard it, we've said it, we'll be dreaming about it, 1 million more midwives. But what does that mean to each and every one of you within your country context? So that's our theme. We've heard a little about leadership from our first speaker this morning. And what better way then to hear more about how we can drive health systems forward than to hear from our excellent panelists. I don't know how you're feeling, but I'm really excited. We have diversity here and unique perspectives from experience. So it's a little bit daunting, so I'm warming up here. We're going to have fun on this stage this morning. We're all going to be really cool and loose and really speak from the heart about our experiences. Well, you are. Anyway, so we're going to move on to our first question. And that question's going to go to Indy. So, Indy, can you share 1 million more midwives is also about ensuring more midwives are educated to ICM global standards so that they can provide high quality, respectful care. In India, how can scaling up midwifery education that meets ICM's global standards reduce over-medicalization and improve women's experiences?
Jackie, thank you so much for that pertinent question. Just as a context, every minute of every day, between 41 and 51 babies are born in India. 25 million births a year. A number so large, it stops meaning anything until you remember that there's a birthing person, family, and an experience that follows. They will carry this experience for the rest of their lives. India has made remarkable progress. Institutional births have risen to over 90%. So access that has been a battle has been won. However, the manpower hasn't increased with the increase in institutional births. Access is not the same as quality. And workforce remains the same. So we are now witnessing something that many of you are probably experiencing in your own countries. The birth volumes have increased medicalizations. And as a result, cesarean sections in parts of southern India have increased more than 80%. Interventions designed to save lives are being applied to people who do not need them, not because clinicians are uncaring, but because systems are not built around the physiology of normal births. But here's a number that tells us exactly why scaling midwifery education must go on to make a real difference. 40% of births in India are now happening in private institutions. And that is where midwifery training must scale up to provide births in those institutions and to reduce medicalization. Currently, midwifery training is only limited to public institutions. The cesarean section rates in private institutions are almost 54%, and in southern states as high as 80 to 90%, and in public institutions 17%, and in some states in the north even much lower, not because women don't need them. So the difference is stark. It is not a clinical pattern, but it's a commercial one. It will not change through policy and statements alone. It will change when midwives are educated to ICM global standards, working in those private hospitals, when they're educated and trained to support birthing people, and through evidence-based practice within multidisciplinary teams. India needs to see the scope of a midwifery practice. Even in England, we are still suffering when midwifery has been embedded for all those years. So at Fernandez, in the hospital where I'm also based in, the midwifery stats have been incredible in the sense they have birthed over 15,000 women, and that's 2025, which is 40% of total births. What they have done is also reduce unnecessary interventions such as routine episiotomies. And these are some things that we take for granted. Our co-located midwifery-led unit, over 2,000 births, and when women are transferred for medical needs, the cesarean section in that cohort of women who've been transferred was 6%. That is because of the midwifery philosophy of care offered in the midwifery-led care unit. And that's why we need more midwives trained to global ICM standards to make a change.
Excellent.
I just also want to name one dimension that we do not often talk about. So birth is not just a clinical event, it's also a biological one. You know, research shows that the mode of birth affects the microbiomes, and that's something that's not going to be availed after the birth as well. So we need to be mindful of what it does to the children. And what kind of midwives? It's not how many midwives do we need. It's the type of midwives that are enabled and are able to change practices back in their environments. So it's not the quantity, it's the quality that will enable them to do that. Yeah. And the curriculum that the ICM on midwifery and direct entry midwifery is so exciting because that is the need of the hour, and that's what the country needs. With midwifery education, direct entry midwife is also crucial. That will change the climate. So let us not just look at a bigger workforce, but a better workforce to enhance and impact the maternal health care. And every birthing person deserves that. And it's a commitment to the children that they bring to the world and to the start that those children deserve from their very first breath. Thank you.
Thank you, Indy. We'll hear more from Indy in a moment, but I really have to adjust this chair because I'm sinking into the back, so just forgive me for 1 second. And I'm just conscious of this side as well, so I'll just sit on the end. Apologies. Excellent. We'll hear more from you. We're going to now move on to Jama. I'm so excited to hear from Jama. Jama, we have a question for you. We know that when crisis hits, we do not rise to the level of our ambitions. We fall to the level of our systems. Could you share more about how enabling 1 million more midwives during stable times has strengthened midwives in Somaliland and enabling them to have an ability to respond to humanitarian and climate-related crises?
Yes, thank you so much, Jacqueline. That's an amazing question. And I think from our experience, we really, really agree with this statement. And it resonates deeply with our experience in Somaliland. Because Somaliland faces recurrent humanitarian and climate-related, from all the screaming yesterday and the day before.
I'm glad you were screaming.
My voice.
Yes, you were engaged.
Yeah. So we have all these reoccurrent issues such as prolonged drought, and then when we don't have drought, we have extreme floodings. So it's the one end, but also the other. So we have disease outbreaks, we have man-made, but also natural disasters. So there's a big scope of these situations of crisis that we experience in Somaliland. But unfortunately, it's women and their babies and children that are the most vulnerable in these situations. Although they're already vulnerable, then within these crisis situations, they are in increased vulnerability. And unfortunately, pregnancy doesn't stop during floods. Babies are still being born during these crises and humanitarian issues. And they are themselves being displaced. They are experiencing part of conflict situations, and so they lose their homes, they get displaced. And so the question is whether in those type of situations they will have the available support, the midwife that's trained, regulated, registered, educated to the right standard, that is placed in the right place to support these women and their babies at that moment. And so we have learned a few lessons, and I would like to give you 3 examples of our experiences. And so Somaliland has created given a lot of investment in midwifery education, for example. In the past 10 years, we've invested so much on midwifery education. We have strong midwifery institutions that are being led by midwives. That is a very important aspect, is the leadership of these institutions. And we have advocated so long to get midwives in charge of midwifery education and midwives in charge of regulation. And that's very important, because it's very important for the midwifery identity when you're being led by your own people. And this is what you were talking about with leadership and investing in leadership of younger generation, to see midwives in charge of their midwifery faculty. That is important because they will then be empowered to also dream of one day leading into these and getting into these positions. But when it's other professions such as doctors, usually, that are leading midwifery institutions, that shows, and it creates a situation whereby the midwifery identity is not there, and that's a shame. So this has increased the workforce availability, because obviously then you have all these midwives that are qualifying and that are in the country and they're available, but we have to work now on the placement of these midwives into the rural areas. where they are needed the most, because those are the areas where women experience most displacement. We have IDPs in Somaliland, and so we need the midwives to be placed in the rural areas as well as in the capital cities and the bigger cities. So now we need, and we're working on midwifery leadership, because unfortunately there's, people think of leadership and think straight away of ministries of health. And yes, I think they are the lead in health, but when it comes to midwifery, I think it's really important to invest in midwifery association as the leaders in that country. Yes. Because although quality education is really important to be empowering or creating midwives that know how to identify risk, that can educate and empower women, that can teach them about healthy eating, that can recognize an emergency situation during giving birth, because they will be the everything to that woman and her family. There is no one else except the midwife in our context. And so they continue to support and lead and advocate for these women. And another example that I wanted to share is to do with leadership. And it's, unfortunately, in our context, ministries of health change. The staff, there's a high turnover of the minister, of the director, of the director general, for example. So when you invest in and pour all your funds into the ministries of health, they will be changed. They will not be in a position after, I don't know, a year and a half or 2 years, which creates, a break into all the efforts that were being worked on. So in our context, there's been a lot of, so after the war, after the civil war happened, we had there was no health service at all. Everybody was either dead or fled the country. So it was the Midwifery Association in Somaliland that strengthened everything that we have available today. Everything. Thank you. So it's the association that invested and led and advocated for the education sector. And as I explained, we have really good educational institutions. Then we went into regulation, and I'm really happy to be on the board of directors of our National Health Professionals Commission, which is our regulatory body. And the reason the association is on the board is because we were the founders of the entire regulatory system. So, yes. So it wasn't just for midwives, it was for doctors, for nurses, for midwives, for lab technicians, and for pharmacists. So we chose not to put regulation within the association, which we had the chance to, but we invested in regulatory body that is for all healthcare professionals. And everybody's very thankful in Somaliland for us having made that decision 5 years ago. So now we have, everybody's on the board together, and we make these decisions together, and we are working hard on making sure that regulation is 100% over the country, which we have not reached yet, unfortunately. So leadership matters, and investing leadership in the right places, because the Midwifery Association is still there, is still ongoing, very strong, and I'm so happy to announce that we have even managed to buy our own building.
Wow.
So, yes, thank you so much. And that is another example of sustainability. It's really important to have sustainability in place so that we will never be needing to ask for rent, or we never going to be needing a space to meet, our own offices, our own. And we are the only association in Somaliland that has done this. everybody else is still aiming to. Yes, thank you so much. And my last example, I don't know how I'm doing for time. I think I can talk forever about midwifery.
I know you can.
Oh,
And we'd all love to sit here and listen to you, but the clock is ticking. But just share,
Okay.
We'll come back to you, Jama, as well, but do share the last one.
Yes, okay, so I have another example where we have managed, together with UNFPA, to send midwives, and we called it the search midwives, into one of the hardest affected region in Somaliland, where a lot of conflict happened. So because we were in place and the collaboration was in place, we were able to send these midwives into the right places to give maternal health care to the women. So 1 million more midwives initiative is not only about the individual, it's about putting the system in place. And the system doesn't work without the midwives being in place. And then climate change is a huge issue in Somaliland, and heat increases pregnancy risk during pregnancy. We all know that. Evidence has shown now that flood insecurity contributes greatly to maternal anemia, poor health, and poor birth outcomes, unfortunately. Flooding increases infectious diseases. There's a lot of things that interconnect, and displacement, obviously, is a high risk for women to experience violence and can cause rape and things like that. So midwives work closely with women and families in Somaliland and communities, and they're often the first and the only person that they come in contact with. So investing in midwives, therefore, strengthens not only emergency response, but also prevention and preparedness. We're trying to get to preparedness to prevent, instead of us, running around when it's too late, because usually it's too late. When crisis is there, it's already too late. So most important lesson is that investing in midwives is important before crisis. And it's one of the smartest investments governments and the international community globally can make, because that is investing and ensuring that midwives are available in the right place in the community where they will be most needed when crisis hits. Thank you.
Jama, thank you so much. So we've heard about the challenges in India, and India's really asked us to, set the pace for reflection about what we're really doing, public versus private, how midwives are really needing their autonomy to be able to work to their full scope of practice, and India has its own challenges, but India's been pushing forward in that regard. And then Jama brings the Midwives Association front and center, buying your own building, being able to advocate at government level, being able to see that ripple effect through the communities. This is leadership in action. Thank you. Now, we're going to go over to the UK, and in particular over to Scotland. And we know that 1 million more midwives, we've heard it before, the number isn't enough. We're hoping that if all countries have their full complement of midwives, they will be able to reduce inequalities, ensure equity for health outcomes for mum and baby. So, Jackie, we'd be delighted, I'd be delighted, we'd be delighted if you could share with us a little about how midwife models of care have helped to reduce the disparity in health outcomes, Scotland context, or whatever you feel you'd like to share. Over to you, Jackie. Thank you.
Thanks for that question, Jackie, and it's wonderful to hear your answers before me. As you can tell, midwifery-led care is part of my DNA. I said that in my introduction, but looking at inequalities are not accidental. They're a political choice impacted by the level of intersectionality of discrimination and the chance of where you're born. And we really hear that very clearly. And addressing them effectively needs the right midwife in the right place with the right skills. It's not just about the number, but the numbers are really important. We have so much evidence about the impact of midwifery and midwifery-led care. We have so many toolkits, but they're pieces of paper unless we have the midwives on the ground that can actually make the difference and take evidence and input, bring it into impact. And that's the leaders, it's the people at every part of our profession. Because midwifery stands at the fault line of inequality. It feels the tremors of political decisions. It hears it's buffeted by the sea change of public opinion, which is no nuance now in a social media space. And that impacts very much because it can bring people up, but it can also create fear and division. And fear is a really lonely place, and that's why we need our associations. Because inequality doesn't just buffet the people that we care for. It doesn't stop at the door, but it also impacts on all the women and people that are providing care. We're all impacted by women's history of hierarchy and inequity of value and inequity of investment. And there is a sustained lack of investment in women's health care in every country.
Yeah.
In Scotland, and in Scotland and across the UK, because of political choices, disadvantaged women live shorter lives and they live shorter lives in good health. It's a political problem, and some of them become pregnant. So we need to be really careful about the narratives that women are broken, that they're making foolish choices, or that midwives are maybe just not educated right. Because actually it's part of a trope that we've heard over and over again through the years. We've seen this throughout history. Blame women, blame the disadvantaged, blame those with the least amount of power. And it all is there to avert eyes away from the systemic failings and the lack of investment. Now, it doesn't fit in with how people often view their country, that the real poverty and insecurity of lives that brought midwifery into homes is there starkly today. And many choose not to see it or to shift the blame onto others and to elsewhere and stoke division. And that's why we need our associations. Because we stand here at the fault line, but how do we weather it when there's political choices that are uncomfortable or when we feel alone? It's about building those connections. It's about coming together, standing strong and moving forward, because that's how we continue to provide the care for women and families. It's the evidence that tells us it's a midwifery relationship that makes a difference. But it's so that women can be happier and healthier and with better life chances, not just to survive. Because by changing that paradigm, it makes sure that we don't provide care that causes trauma and causes harm. And the most effective intervention is the strong, trusting relationship with a midwife, and that's why we need the midwives where they're needed. But that means we need our midwifery community to be happy and healthy and with better life chances and opportunities so that they feel safe. And that's why safe staffing does equal safe care, and that's why that's at the heart of our campaign in the UK. Because professional associations, they're the heart and soul of our profession. They're without borders, they're without political affiliation, and they weather a long history. It's why the RCM was part of setting up the ICM in 1954, because we know we're stronger and better as a global profession, and that helps us all to withstand whatever is happening within our countries. Now, Scotland. It's a wee bit weirder than India and Somalia, but it's small, but it's mighty. And our midwifery community is going from strength to strength, but that's not by accident. It's our networks that is driving forward advocacy and change. Yes, we were the first UK country to have a chief midwife. We do have directors in nearly every health board, but it's a grassroots swell of midwives having a voice that makes a difference and bring change. It's our student midwives that stood with us and lobbied government, and they now have got a 3-year job guarantee and a raise in their finance, so that because some were using food banks in Scotland. It's our early career midwives that have pushed for a preceptorship programme that is now implemented across Scotland, and we're now seeing retention. They are leaders. They are our leaders, and they're going on and continuing to lead in our profession. It was our members' voice that negotiated when they didn't like the pay offer, but that was how we negotiated having a midwifery and nursing task force. And that was to make sure that every midwife thrives and is valued, and we're continuing to work with the government to make that implemented. So our voices together are what brings us strength. But also, when inspections of maternity care were introduced, it was at our conference that Professor Mary Renfrew stood up and challenged the inspectors with our methodology and told them they were wrong. Now, we've continued to lobby because they were only looking at acute care, and we all know that care is important in rural areas and across the continuum. And so, come September this year, those inspections will now go across the whole continuum of care, wherever women's lives are, and will reflect the standards that we were part of, and those standards include midwifery models of care, but they also include the workforce has to be there to make sure that that can be implemented, and that means all parts of the workforce that's needed. So last week the Scottish Government announced a review of maternity, and due to midwives' voices being heard, key to that is workforce, and key to that is care across the continuum in urban and in rural, and that's the power of our community coming together and having a voice. So we have a SMILE network in Scotland, and that's Scottish midwifery leaders. And then round that table are our student midwives, our chief midwife, our directors of midwifery, and all of us together are working now on trying to increase the number of births in our midwifery-led settings, which have gone down since COVID. Because there is no hierarchy in our community, just the valued voices and strengths of midwives coming together and being heard. So addressing inequality starts at challenging it at every level. Women will thrive when midwives thrive. Valuing all voices is as important for those receiving care as for those providing it. So when we stand at the fault line of inequalities, and you feel alone, and you can feel the ground shaking, by reaching out, not just with one hand, but by creating networks that bring strength and amplify the voices of our communities, that's what makes us strong, and that's what makes our professional associations strong, and that's every single one of you in this room. That's where the strength of our profession sits. Thanks.
Thank you so much, Jackie, for sharing the strength of leadership in Scotland, and I'm sure that, of course, ripples across the borders in the UK, and putting that inequality and equity piece within the context of not just more midwives, but midwives in the right place, the right time, with the right building blocks. So thank you so much for sharing that. We are moving from Scotland to Namibia. Sylvia, we talk about 1 million more, but we're really trying to look at what 1 million more means to Namibia and what that will mean to the workforce, and how the workforce then can work to their full scope of practice, if you will, and provide care for women and babies in Namibia. Can you just share a little context around that for us and for the audience? Thank you.
Thank you very much, Jacqueline. For purposes of this talk, I'm going to focus on the midwifery workforce and its contribution to sexual reproductive health and rights, particularly. Namibia, for those that are aware of it, small population, big country with unique challenges when it comes to healthcare delivery. So when we speak about the health workforce in Namibia and the midwifery, we cannot have this discussion without acknowledging the work of the Midwives Association in Namibia. Please give it me really. Namibia, our setting is that we are all trained to be nurse midwives. And this has meant that midwifery aspects were conflated within nursing. And with that conflation, aspects that were related to midwifery were not given due recognition. Midwives were left behind by career progression. And even the services, maternal and health care services within the ministry were overlooked because the assumption is that once a nurse is on the table, they are vocal or they are qualified to speak on matters related to midwifery, which is not the case. Even I myself, when I was practicing, I came to realize that for you to be a midwife, you have to be intentional to focus in midwifery for you to grasp exactly what it is that is needed. So, of course, you've known, I tried to run away from midwifery because it was high risk. Then I went to take up the law profession to go and defend my fellow midwives because of the high risk of the profession. Unfortunately, life would have it the other way. I came to prosecute my fellow colleagues. Well, that was not what I wanted, but it ultimately led to the conversation that we are having today. So in the role of now having been serving both women, public members, as well as the midwives, and trying to investigate the complaints from the public, we came to understand what are the nitty-gritties that the healthcare system is exposing these two women, the member of the public, as well as the midwives, and how we were having challenges retaining midwives within the healthcare system, because we don't speak much about the high riskness of this profession. So for us to strengthen the sexual and reproductive health services, it was not about increasing the number of midwives. It was about enabling midwives legally, institutionally, and professionally to practice to their full scope. So much of the work has therefore focused on strengthening the environment within which midwives operate, because even the most skilled midwife cannot function effectively within systems that do not recognize, support, or protect their role. So our first target of our revival strategy was regulatory visibility and participation. Through the advocacy of the Midwives Association and engagement with the regulators, we have started seeing the regulatory body now focusing into midwifery-specific legal instruments and also updating the old ones. And then we've also now seen that midwives are being represented in the regulatory body. We have a midwife on the council now, on the board, and we have midwives on all the committees of the regulatory body. At the moment, we are also undertaking a process of renaming the nursing board to Nursing and Midwifery Board. While this may appear symbolic to some, for us it's deeply meaningful because a name matters as it encourages visibility. Once midwifery becomes institutionally visible, it becomes easier to advocate for midwifery competencies and leadership to the ministry's top management, which we don't have at the moment. We have registered nurse positions within the ministry, but not midwifery yet. So with this renaming, we are hoping that we'll be able to do this effectively. Also, I'm very happy that for the first time, the Nursing Board of Namibia has sent delegates to be here today with us in Lisbon. So that was our, sorry.
Some water. So that was yesterday, all the screaming yesterday, where, yeah.
So that was the first aspect where we had to deal with the regulatory aspect. Now, the second focus was legal literacy as well as professional empowerment. In many settings, especially in Namibia, midwives practice under immense pressure. There's a fear of litigation, fear of disciplinary processes, fear of being blamed when systems fail, and fear associated with providing aspects of sexual reproductive health care, particularly where abortion-related care is involved. So what we discovered is that fear can quietly influence practice, that sometimes practitioners become more defensive. And with such a mentality, lawful services are often delayed or denied. Sometimes women receive incomplete information because healthcare workers themselves are uncertain about the law or about their professional obligations. So our work has thus been helping midwives understand both their legal obligations as well as their professional protections. You can't do one without the other. We have trained healthcare workers on professionalism, human rights, conditions of practice, disciplinary processes so that they can practice with greater confidence, ethical clarity, and accountability. And when midwives are empowered this way, women benefit directly. So women are more likely now to encounter a healthcare worker who can explain their rights clearly, provide options without fear, and navigate referral pathways appropriately. And women experience less judgment in the healthcare system, less misinformation, and less unnecessary delay or denial within healthcare system. And we need to understand that these delays and denials are not intentional. It's because there's uncertainty, especially when it comes to sexual reproductive health and rights, and midwives fearing whether they are going to be accomplices to whatever it is that they think is happening. So the third area of our focus included engaging healthcare workers on their legal framework surrounding abortion, child marriages, consent, consensuous objection, and the rights of women and midwives within healthcare systems. And with this work, we've really gone deep in having deep discussions with healthcare workers because we assume that healthcare workers don't care. But these are people who are passionate, but who feel are not protected and are thus not offering the services. Because when you don't feel protected, you rather abstain from offering something and then exposing yourself to risks and nobody there to help you when you encounter such problems. So we focused on that so that midwives can provide these services competently and confidently without fear, so that women can experience and get the most out of the system. I was very happy to see the new ICM midwifery competencies making provision for the sexual reproductive health and rights. And we are working tirelessly now to ensure that we domesticate the midwifery competencies in Namibia so that this becomes part of what we rely on and that our midwives are trained on, so that it's not just something that is done at continuous development level, but already from the basic, in the training of midwives, that they are competent already and are able to offer these services within the framework that we have in Namibia, so that women don't have to suffer and midwives don't have to practice with fear. So with this, really just our example has shown that we need to take the leadership. Midwives will lead. We need to take the leadership and to have these conversations, hard conversations, ensuring that we speak up and make sure that midwives are supported, number one. I think we have the research of the repro rights that set out that most of the problems that midwives experience are not because of clinical knowledge, but because of the structural barriers that need to be addressed, and we need to be intentional in addressing this going forward. Thank you.
Thank you. Thank you, Sylvia. You've brought a different perspective to the panel, and we've really stepped into the space of vulnerability, fear of litigation, all those things that intimidate midwives, where midwives need to be strong and empowered for women and their babies. And thank you for highlighting the significant work that Namibia is doing to help women and newborns in that country. So we've heard from each of our panel, but we're not going to stop there. We've just got a short period of time. And I'd like now to let's just push you a little, although you have been pushed already. But there are two questions, and maybe just a couple of you will answer these questions. You've each shared powerful examples of how, if we look at the 1 million more within country context, what that does to midwives and to the lives of women and newborns. But looking across your experiences, what has been the greatest challenge you have faced when advocating for midwives? And Magda shared something really poignant earlier, you know, about standing alone and having the challenges of being a female leader. Of course, we have male midwives, and it's amazing. But here on the panel, can you just share what your biggest challenges you feel might have been when advocating? And if we can come maybe to Indy and then to Jama, if we can be...
Yes, thank you, Jackie. I'm going to share that question with a moment rather than an argument. I was in a public institution mentoring midwifery students in a clinical placement, and we were with a woman in labor. She was HIV positive, and we cared with her with the compassion, eye contact. She looked at us and she said, "Why are you being so nice to me? I'm HIV positive. In my first birth, I was pinched and shouted at."
Pinched and shouted at.
She was not asking whether we were competent. She was not asking about our guidelines, not about our training or our scope of practice, but she was asking why she was being treated as a human being. That is the greatest challenge I have faced advocating for midwives in India, and that's why you need midwives translating the ICM into best practices. And it's not just about the curriculum, treating each and every woman, despite her background, regardless of her race, that care that she deserves. This woman, at the most vulnerable moment in her time of birth, did not face that, her basic human right.
Thank you, thank you. And that wasn't 30 years ago.
That was in 2018.
We've got to do better. Thank you for sharing that and your advocacy approach. Jama, can you share a brief example?
Yes, very brief example. I think Somaliland is a very male-dominated space, in every space. So, for example, in our parliament, we have only one woman, for the whole country. And so women leadership is something that's not new. It's just, you should lead, and you're supported to lead, but down there somewhere. You shouldn't come to the forefront. You don't need to be seen. You don't need to be in the media. You don't need to be, talking too much or too loud. You should always protect or keep the status quo the way it is, because it's there for a reason. There's somebody somewhere that needs it to be this way. So in Somaliland, we have been so lucky to have women that are unbelievably amazing and strong. I want to give out the example of Dr. Edna Aden Ismail. I'm sure a lot of you know her. So she's always advocating for midwives, always advocating for Somaliland, always advocating for leadership, and she's a visionary. She meets with us regularly at the association. She's one of the founders of the association, so she knew, she was working for WHO in 1960s. She was the first midwife in Somaliland, first to come back, first to start education, regulation, and all of that. And we have had, for example, made good use of our previous First Lady. She was a midwife, educated in the UK, became First Lady, and she was everywhere for us as well. So it's making use of the right people in the right positions is very important, and that's how we did it.
Thank you to both of you for those great examples and intentional leadership. I loved what both of you said, and I'm sure the audience did too. We're going to move on to the final part of this plenary, and so we have got some time to take some time to respond to this killer question. And the killer question is, we have some 3,000 plus delegates in this room and probably outside in the exhibition areas as well. You've experienced from your country context, your strength of leadership, some of the challenges, some of the areas that you've had to fight and battle hard to advocate for who we are, what we do, despite the evidence. So I would like each of you to share with the panel, to share with delegates and each other, if you had advice that you could give to delegates right now about leadership and how to move forward, what would that advice be? Bearing in mind, we know that one size does not fit all, but nonetheless, we have some experiences that have proven themselves in country. So, I'm going to go right over to Namibia now. just warming Sylvia up here. So we're going to go step into the amazing, beautiful country of Namibia, and we're going to hear from Sylvia.
With leadership, don't wait for the title. Start where you are. Use what you have. Your voice matters. And when you see a gap and it's within your competence, do it. So that's really my advice for leadership, because when you wait for titles, we might be denying people services that are within our means to offer. And something that this is more advice to me, just because you can and you know how to lead, shouldn't stop with you, pass it on and let it be known, because then replication enables sustainability. Thank you.
Thank you. Thank you, Sylvia. You know, I think one of the, as a leader, I find that I learn best from people that are not like me, and I learn best from people that are different to my usual frame of reference. And as a senior leader in age, I would like to say that it's really important that we listen to our emerging leaders, to our middle grade leaders, and indeed our senior. We should always listen, because there's so much to learn. Thank you, Sylvia. Over to Jackie for her pearls of wisdom.
So, and this is something that I learned from somebody else, and this is about being a lighthouse. That no matter how stormy the water is out there, find your lighthouses, find those people that and become allies to other people. But also, when you look around and you don't see somebody that's your lighthouse, then you're it. So make sure that you're making that space for everybody else and making sure that they can see that there's light at the end, and actually there's somebody to hold on to. So it's sharing and actually being a lighthouse for other people.
Wow. I thought for 1 second there that the midwives in the UK were going to burst into song, My Lighthouse, but we've been saved from that. But isn't that, metaphorically speaking, quite significant? If you can see that light, then you can follow. You know, when things are challenged and there's chaos, if you can see that light, and it's a strong light, is what you're saying, Jackie, right? Thank you. Thank you very much. Let's step into Somaliland and let's hear the pearl of wisdom from Jama.
Thank you so much. So I would say to everybody here today, everybody comes from different backgrounds, you're in different positions. I would like to advise you to focus on strengthening systems, again, and the midwifery associations. Always look in the room. Ask the question for any delegates that are there to work with you, or your partners. Where are your midwifery associations? Who is here from the association? Do you know anybody? Could you bring them into the next meeting? Because I think once the midwifery associations all around the world are there into the right spaces, where, because everybody's talking about midwifery nowadays. That one thing we have got right. And I'm very thankful for that. But the problem is, there's midwives in the community, there's midwives in education facilities, there's midwives in the ministries, but they're not empowered. And they don't know the global situation, they don't know the country level situation, but the associations do.
Yes.
And so if you do your best, please, to empower in your capacity, wherever you are. If you're an emerging leader, if you're a midwife working in anywhere, please also join your association. Understand the importance of strengthening associations through knowing your own association. Register with your association. Know who your leaders are. Then it will be easier for you to follow them, to strengthen them, to support them from you know, as you said, Jacqueline, everybody is a leader, but, you know, you lead from where you are and you start there. Thank you so much. That's me.
Thank you. And finally, we're stepping into India at the moment.
You're so right. Each and every one of us has that element of leadership in us. Don't just see the light, hear the voice. If you see something that's not going right, be brave. And that's how we're going to change systems that are not right, I feel. Thank you.
Fantastic. So thank you so much. We have the theme of 1 million more midwives, and each of our amazing panelists from their expert experience have shared what that 1 million midwives means to country, means to women and families. We've touched on equality, equity, midwife models of care. We've touched on private sector. We've touched on midwives associations, and we've touched on that vulnerability of practicing defensively. And here our leaders have demonstrated from India, Somaliland, Scotland and Namibia the strength of midwifery leadership. Thank you to our amazing panel. It's not easy to sit here and get out everything that you want to share, but I think they did a fantastic job. So proud, so delighted to be your moderator. Thank you to our panel. Now it's time for you to have a quick coffee, I think, and over to your next session. Thank you. Thank you.